All right, these are always very entertaining and very exciting. We're going to start our debate. Today's debaters, hailing from a small town in Arkansas. You know him from the Heart Hospital as a PCP, now returning as champion heart surgeon. Give it up for Dr. Chris Freeland. And from Russia, Dr. Vasily Lendl. I've been told I have to officially start the debate with this 25-cent piece that was given to me by Vicki Wingfield. Vicki, thank you. It'll go back to the foundation when we're done. We'll let Dr. Lendl call it in the air.
What do I call? I'm from Russia.
Correct, it's heads. You get to go first. Let's get ready to rumble!
Well,
that's me.
No, but that's that'll be a great debate. First of all, thank you, Dr. Dixon. I have made the right choice in my specialty. I know. Thank you. But you go ahead.
Right, give me a clicker.
Uh-huh.
You're already losing, man. Can we see the slides? Thank y'all for this opportunity. Where are the slides? Can we see them? All right, I'll just start off. Who's? Tell the joke.
In fact, we decided not to do a debate. There's nothing to debate here.
We're just going to sit up here and spar.
We're just going to talk something funny. Maybe bring a colonoscopy slides if you... Mine will be short. I will be done in an hour.
Okay, I win. I'm out. Not awkward at all.
We should have just went with his slides the very first. Yes. You're going to coin again?
No, I was thinking, as we're waiting, maybe they could actually tell us what they're debating.
Indeed. We're going to be debating about superior treatment of coronary artery disease and revascularization of coronary artery disease using stents and some other things.
Can you define some other things?
I will show you pictures. I have visual art.
I'll show a video from last night.
And videos.
All right. Well, Dr. Lendl's time is already up. So there's a red light flashing here. So we're going to let Dr. Freeland go first, but they can't find your slides. So
I gave it. I know.
They were just up. There they are.
Oh, here we go. Okay.
All right. Can we get them on the big screens? The big pretty screens?
So let's get the slides up on the side screens if we can.
All right, ready?
Well, we'll go start with this.
Okay. So what we're talking about today really isn't a debate at all. It's been played out in the literature for years. The only way that you can really argue it is if you start changing the terminology and start doing some fancy tricks to the data. But CABG is better than PCI for multivessel disease. That is a bold statement right now, especially as outnumbered as I am standing up here with everybody in the room. But it's a true statement. To make that statement, and you have to kind of understand the basics of what the treatment modalities are. So PCI is placing a stent across a lesion. And what you treat is the high-risk lesion that directly lies underneath the stent. CABG doesn't treat these lesions. What it does is it bypasses these high-risk lesions that are proximal in the coronary arteries. What does this matter? Why is it important? If you look at this study in 2001 where it looked at high-risk lesions and their locations, 56% of high-risk lesions in the LAD were found in the proximal artery. That was before the second diagonal. A Lima to LAD bypasses 50% of future lesions. This was also found in lower numbers, but it was also found in the right coronary and the left circumflex artery. So why is it better than PCI? Well, PCI treats a specific lesion. So the benefit and risk is lesion specific. This leads to minimal enhanced survival. CABG bypasses that lesion, but it also bypasses future lesions. This is where you get the enhanced survival associated with CABG. This is a picture just kind of showing the difference in them. You have the stent that goes across a specific lesion, and then a bypass graft that bypasses all of that stuff. So the survival advantage of CABG still exists even if stent thrombosis is 0. Now let's look at the data. This was one of the first studies that was done. It was a review of the New York State Registry looking at stent versus CABG in multivessel disease. And this included 2-vessel disease, not just 3-vessel disease. There was a significant advantage in survival as well as incidence of adverse cardiac and cerebrovascular events out to 3 years. Now this is more of a historical study because this was bare metal stents. This wasn't drug-eluting stents. So the companies and guys like Dr. Lindell tried to say, well, we have better technology now. You surgeons have been doing the same thing every time. Well, luckily, a few years later, they looked at drug-eluting stents. The same thing played out. There was a significant difference in survival and an increased incidence of adverse cardiovascular and cerebrovascular events associated with CABG and multivessel disease. These graphs you're going to see over and over in the studies. They never change. They're the same thing repeatedly. But this does give you an idea of the attempts that we continue to try to make to show that PCI is better than CABG. The Syntax trial, this was a great trial. At this point, they had realized they couldn't prove PCI was better than CABG. So what do we do now? We try to say it's non-inferior. So they were not able to prove that. The hypothesis was not able to be proven. So then they broke it down into subgroups: low risk, intermediate risk, and high risk, based on the Syntax score. And the Syntax score is just an anatomical score of what the lesion looks like and their risk. What they did find was that in the low risk, PCI may be an alternative to CABG. But at intermediate and high risk, CABG still maintained a survival advantage and decreased incidence of MACE. The next big trial was the Freedom trial, where we looked at multivessel disease and left main disease in diabetics. It's the exact same thing. But these things carried across all Syntax groups, regardless low, intermediate, or high risk, if you had diabetes. Based on this study, no patient with diabetes should ever come to the operating room with a stent and multiple coronary vessels. And another thing, I didn't put a slide on it, but the incidence of revascularization, having to return to the cath lab to have more stents placed, is so high compared to CABG that we try not to talk about it. But it is ridiculous. 12% at 1 year in some studies, even higher in other studies, which means you didn't do a good job the first time. You didn't treat the disease. They don't come back to the cath lab because they didn't have nothing to do on Wednesday. They came back to the cath lab because they're having heart attacks or they're having angina. And this is the very thing that drives the survival advantage with CABG. So in conclusion, CABG is consistently shown through randomized controlled trials and registry data to be superior to PCI in regards to survival and MACE in multivessel disease.
Well done. Now, we're going to go step by step and debunk all this. And this is a great presentation. I'm glad my slides were lost so I could go second, and we'll decide. Now, so you heard right now, bypass better, isn't it? Well, let's see why we're doing a bypass. Why are we actually doing any surgery? Why we do stents? Symptoms, possibly survival, and prevention of MI, CHF, and maybe arrhythmias. Now, since bypass is better, probably most people should have a bypass, but wait a second, there's a ratio of 1 to 4, approximately, considerably more angioplasties performed than bypasses. Well, you could say, maybe it's only in the United States. How about in the world? Maybe they're smarter than us. Well, let's look at it. United States, 1 to 4, we're kind of in the middle. There are countries like Canada, then the ratio is 1 to 2, but there are countries like France and Spain, there's almost nobody gets bypass. Everybody gets stents. And that's with the invention of newest stents, like a bioabsorbable stents and newest technologies. Now, let's talk about bypasses. Indeed, bypass compared to medical therapy offers you survival benefit. That's all true. And if you asked me this question 10 years ago, I would have had to say to you that the stents don't offer you survival benefit. They treat symptoms, but I cannot tell you they're going to live longer. And with the early generation of stents, like bare metal stents, like angioplasty, that's what was true. However, with the new generation of stents in the past, we now can say that they do offer survival benefit. The vascularization, indeed, Dr. Freeland told you that, without any doubts, if you're talking about repeated procedures, indeed, bypass wins. We will come back about this vascularization issue. I just want to tell you that there are probably 280 articles devoted to just exactly the same debate what you, Dr. Freeland and I are talking about, bypass versus angioplasty. There's probably several dozens of meta-analyses where the data gets combined together and gets published. This is the data from a thoracic surgical literature where you don't have to go into details, but it has survival benefits. Everything to your left favors PCI. To the right, or survival to the right versus bypass. Now, how about stroke after bypass? That's a kind of minor complication sometimes you get, and then you cannot walk in a wheelchair. Clearly, PCI is better than bypass. Now, but you could also say, okay, no, let's adjust the data. Let's adjust the data because something is not right here. And the same journal publishes the follow-up to the study I showed you before with the meta-analysis says, no, we adjusted the data. And adjusted data shows better. Well, this is unadjusted data. This is adjusted data. And now, let's talk about that syntax trial we were talking about. Syntax trial was done approximately 10 years ago. Uses Taxus stents, which you have not been using for the past 5 years. The stent is off the market right now, all technology. However, if you look at low-risk score, intermediate score, and high-risk score, and the score is that you take in locations of the lesions, you say that if they're calcified, not calcified, and you apply it, and you can come up with a score. And if the score is indeed very high, in other words, you're really, really sick, yes, bypass is better. Again, we'll come back to that issue. But with the low intermediate scores, survival benefit is very little. Now, again, I told you about that it's all technology, Taxus stents. How about the newest stents, everolimus or eluting stents? If we're talking about death, MI, and stroke, that really matters. No difference. However, if you want to make a difference and show, you add one more called TVR, or revascularization, or total lesion revascularization. How about, you already saw slides from New York State. Newest stents, everolimus. In terms of death, no. Revascularization, yes. But this is your revascularization. Takes an hour. Simple, easy, very low risk. Now, let's talk about something a big taboo in the angioplasty world was always left main coronary artery. How about those people? In a low risk, left main, similar results in a death and survival. In the high risk, with all the technology, again, there is a benefit of bypass. However, if you look at the newest trial, which just came out last year, among 2,000 patients undergoing bypass versus angioplasty of left main, all-cause death essentially is the same. And they went up to 3 years in follow-up. If we take the last 6 trials of the past probably 7 or 8 years, 5,000 patients, randomized trials, bypass versus angioplasty, we have very, very similar results. In other words, mortality benefit of a bypass over angioplasty has diminished, and we're essentially right in the middle. Now, indeed, you saw a slide for Freedom trial. Now, it's an important part about the Freedom trial. Indeed, diabetic patients, you start seeing difference only after 2 years after bypass. So after 2 years, it's the same results. However, the same New York regency suddenly shows that there's very little difference between bypasses and angioplasty in diabetic patients. Now, so we talk about death, MI, stroke. Important issue, isn't it? But there are other trivial components of bypass. I mean, you have a bypass, who cares? that's a successful surgery. Means you have a great survival benefit.
You're out of your mind.
This is another example of a great successful surgery.
Nobody does this.
That's another. There's no MI, there's no stroke, and it's a successful surgery. How about this? You can spend in the hospital for a month. It's another great success. But that tells us how the trials run. In other words, it's a flaw in how the trials designed, because the endpoints of the results, death, MI, and stroke, important. But when you read about the trial and really make a difference, well, there are other issues we have to discuss. Now, here's the final slides on all this. We talk about the syntax trial, which is indeed a pivotal trial in our world, where we really rely on those who goes to bypass surgery versus we offer them angioplasty. And this is just to my advantage. I was surprised to see this trial came out only 2 weeks ago. I said, okay, that's perfect. We're going to use it for the debate. How about if we talk about complete revascularization? Until recently, indeed, bypass offered often higher percentage of complete revascularization of any of the lesions. But if you can offer the same with the angioplasty, and the current technology offers that, over the past 10 years, great advances in, for instance, in angioplasty of CTO, chronic total occlusions came. And we're talking about complete revascularization. You realize, so the first line, you see the dotted line, that's when you complete incomplete revascularization. Bypasses are better. But when you offer a patient complete revascularization, there's absolutely no difference in 5 years. Now, short-term benefits, well, small. Strokes, MI, bleeding, renal failure, prolonged intubation, arrhythmias, all less. This is an editorial done by Eugene Braunwald. Every cardiologist knows the head, essentially for the past 20 years, the most influential figure in cardiology. The outcome of shorter hospital stay, greater earliest benefit, rapid recovery, return to normal activity, and over bypass clearly. And this is a patient who had repeat revascularization yesterday, happy as a clam. Thank you.
All right, guys, in the middle. We're going to ask the audience, if you had multivessel disease, would you want to have heart surgery? Applaud if you want heart surgery. Or would you prefer to have multivessel angioplasty by him?
The key here is indeed in complete revascularization. And what really determines if indeed somebody has significant coronary disease, bypass wins. But that has been, over the past 10 years, less and less and less patients.
Making stuff up.